Okay, so now we can start the scientific program per se, and I'm glad to welcome David LYDEN. And a few words about the speakers. Wait. He's professor of pediatrics at Weill Cornell Medical College, and since 2013, that's correct, I believe. He's also professor of cell and developmental biology at the same place. I think he's well known for his research on the mechanism by which cancer metastasizes throughout the body. A very important topic indeed. And particularly, he has studied the role of blood vessel that tumor needs to grow and spread. And his laboratory is studying the biology of a particular tumors, the medulloblastoma and high-grade glioma. His lab is indeed working to understand how the cell and its environment actually contribute to the growth of the tumor and to its dissemination. And I find on the internet an interesting statement, personal statement by David, which says, "I'd like the result of my research to be used to personalize medicine for each patient, to make it more effective with fewer side effects. Each child secured makes everything I do worthwhile." That's a great statement. Thank you. And now he's going to talk about a topic that has become very popular, which is not absolutely new, but he's going to tell us exosome, this mysterious and heterogeneous population of vehicles that actually are produced by cells, tumor cell as well as normal cell, and their importance in various diseases, including cancers.
Great. Well, thank you so much for those kind words, Daniel. And I want to thank the organizers, and it's really an honor to have Louise, Harel's daughter, here. So what a remarkable, her whole career was really outstanding. So I just feel like I'm a little fish in the big pond with Louise Harel. So hopefully I could add something to the meeting. So thank you so much. And I'm also very excited that the other speakers today are really, my cherished colleagues. So it's very exciting to be here overall. So today I'm going to be talking about something that's actually not such an unknown area, since the Curie Institute are leaders in extracellular vesicles in the world. So I'm going to be complimenting some of the work that's already been done right here. And they're the size of viruses, and there actually is a particle that's even smaller that's involved in the heterogeneity of cancer, is one of the themes today. And they can really be secreted by tumor cells and the cells in the tumor microenvironment. And they can really have an impact on metastases, since they're traveling in the blood and are taken up by distant cells. So cancer, if you just learn one thing about my lecture today, is a systemic disease. We often just focus on the tumor. Oh, let's look at the cells around the tumor, all in the primary tumor, but that's not exactly how a cancer patient shows up with, oh, I just have a tumor. No, they usually have a lot of complications. And each organ we have to think about are affected when you have cancer. And as Louise Harel, she's at the Growth Factor Club, she was almost on the same theme that I'm focusing on, systemic effects, growth hormones, and stress factors, and exosomes. They all have a major role in this whole process when you have cancer. This is supposed to click. There we go. These are my disclosures. And here's a really nice EM picture of what I'm going to be talking about. So you could see here's a large exosome, or an extracellular vesicle, as we call it. And then there's smaller ones. And then these tiny little particles missing a double lipid bilayer are what we call exomeres. These are what we study because we study the distant organ. We actually work backwards. If you have like melanoma, I'm not really interested in the primary tumor. I'm really going to focus on the lung, where it's going to metastasize to, and it's going to kill the patient when it gets to the lung with its spread. So what's happening in the lung even before the tumor gets there? You'll be surprised. There's enormous amount of inflammation, ECM changes. And so do the exosomes that I'm showing you here have a role in all those changes at distant organs? And so here are the leaders at the Curie Institute. So Graça Raposa, she's been working in this field around 30 years, defining all the biogenesis. And here's a paper from Clotilde Theory. And, you know, they're pretty much running the show in the world on extracellular vesicles. And so my contribution is more related to metastases. So it's in a very exciting time. They started the International Society of Extracellular Vesicles. And when I started the work, there was only a handful of people working on this field. I don't know what I'm doing here, but hopefully. And excitingly, our last meeting, there was 3,500 people that attended our meeting. So this is one of the fastest growing areas of cancer. Besides, everyone's so excited about immune therapies. This is like probably the second fastest field. And so here you can see there's larger vesicles that are very important in the primary tumor, like a microvesicle. There's Clotilde defined in ectosome that pinches off at the cell membrane. And then there's the smaller exosomes and large exosomes. They're made near the nucleus. They're very different. They get packaged in these large multivesicular bodies and are released. And then we recently discovered the exomere. Mere means minuscule. And we don't really know where they're made yet, but as I'm going to show you soon, they actually, all these free particles are the ones that are found at these distant organs that we study, and they package different molecules. And we have to understand what those molecules are. Can they serve as biomarkers? But more importantly, do they have a functional outcome, you know, really promoting the systemic disease of cancer? And here's a nice cartoon of an extracellular vesicle. There's proteins, there's DNA that my lab's studying as well. What does this all mean? And surprisingly, even the DNA is presented on the surface of the extracellular vesicle. So what does that mean? Here we have tumor DNA or immune cell DNA, and it's sticking outside. Does it have a role in immune cell to immune cell recognition? And the proteins that are sticking out also are important for biomarkers. And this is good because you can develop drugs and block tumor exosomes from being taken up by recipient cells. So it's like there's a lot to be learned what's packaged in these extracellular vesicles. But one thing, don't make the mistake of thinking they just represent whatever's in the tumor cell or the immune cell. They have specific packaging. And so that opens up a whole new area of cell and molecular biology, trying to figure out why something that might be lowly expressed, say in the tumor cell, that you say, oh, I'm not going to develop a drug because that integrin's not really that well represented on the surface of the tumor cell. But then you're surprised when you look in the extracellular vesicle and that integrin's highly expressed. And if you had a drug, you would block those extracellular vesicles from being uptaken in normal tissue, such as the lung, where it promotes a lot of inflammation and immune suppression, a perfect environment for tumor cells to go to. Here we are with the systemic effects of cancer, which I have to say is still by oncologists. People who even take care of cancer patients don't appreciate. And as I said, mainly most of the people are focusing on the primary tumor. I think just recently they're thinking more about pre-metastatic niche formation and where the tumor might go, but it goes beyond that. You can actually die from cancer even beyond metastatic burden. And so do the extracellular vesicles have a role in cachexia? When I first heard that word, I said, that doesn't sound too interesting. A little bit of muscle wasting, fat wasting. And then one of the first cachexia researchers, she said to me, well, if your heart is 50% less than it was, and you could die from that. If your diaphragm is wasting, you can't breathe. And that really woke me up, that she is absolutely right. And of course, we know about immune suppression when you have cancer. Do the extracellular vesicles have a role here? Your brain, you could have a cancer patient presents with depression, anorexia, but also can present with like a seizure. Lung cancer patients also often present with a seizure and a lot of neurotoxic effects. And you think, oh, does this person have a brain tumor or a neurological? You can be fooled for months, and it turns out to be a primary lung cancer. So that's very common in a lung cancer patient. And of course, you can get diabetes and clotting. It's really embarrassing that clotting is the second leading cause, and advanced cancer, that we have no drugs for the metastatic patient. Everyone says they die of metastatic burden, but in fact, they're dying of clots at the end. And how many people are studying clotting in cancer? Probably 3 or 4 people around the world, and it's the second leading cause of death. So you wonder, what's happening here? When I started metastases researcher, there was a handful of us, Joan Massiquet at Sloan. We could name the people like 1, 2, 3. And here, that's the leading cause of cancer. So I think we really got to pay attention to the cancer patient, and we have to really pay attention and do something for advanced cancers that we're not really, we just say, oh, we don't have the drugs, enjoy your rest of your life. And, that's ridiculous. That's been going on for the last 50 years. We really got to change things. And so I'm going to also present that these extracellular vesicles can really shut down an organ. So if you shut an important organ down like liver, you're really in trouble. How are you going to metabolize chemotherapy that's supposed to get rid of the cancer? How is your immune system going to work if the metabolites aren't made, such as arginine, creatine, and creatinine, go down to nothing when you have cancer? So there goes your T cell function. So that's what I'm really highlighting here. And we have a recent paper that's hopefully going to come out in Nature Medicine, that we get liver biopsies from patients undergoing pancreatic cancer. Everyone in the world says the liver's normal, so you can have surgery, there's no tumor cells. But here's just to show one cell type, NETs. I don't know if you guys have heard of that, neutrophil extracellular traps. It's basically DNA of the neutrophil and histones and other molecules that actually go to the outside of the neutrophil. That neutrophil dies, but it's supposed to normally trap bacteria when you have an infection, but it's doing the same thing here. And this is a picture of a liver. And look, I don't even have to, for histologists, you don't even have to go far. It's covered with these nets that are trapping tumor cells. And so if we see a lot of nets in the liver, the patient dies in 3 months. So you wouldn't, if you do a little biopsy at time of surgery and see that, that patient shouldn't go on and have a Whipple procedure, which is torture. And you should have other systemic therapies. So this biopsy tells us 4 groups: who's going to die right away, who's going to have liver mets 1 or 2 years later, who's going to have lung mets only, which is 20% of all pancreatic cancer, and who's going to be cured. We actually, with all your fancy chemo, we already know right up front who's going to be cured, because that's the patient that has normal liver. So I'm going to show you some of that in one moment. So luckily we've had so many talented people in the lab. Bruno's back in Lisbon running his lab at the Champalimod Foundation. And Ayuko, I'm proud to say, all like the women in my lab do like amazing accomplishments. And Ayuko's now a full professor at University of Tokyo. She only went back to Japan 5 years ago, and I never heard of anyone moving up the ranks. But there's only 5 women, can you imagine, in the whole University of Tokyo that are full professors? So obviously, I think the Japanese government is changing rules finally. And so she's doing well, and together they first described another big mystery in cancer. Stephen Paget, a British physician, who described the seed and soil hypothesis. Why does cancer spread to certain organ sites? Do the extracellular vesicles have a role in organ tropism? And so here we take this triple-negative breast cancer by the Massaquet lab. So you have a bone tropic, a lung tropic, and a brain tropic subclone. You just grow the cells in culture, in the media. We spin that down using ultracentrifugation. And we can label these exosomes with different lipid dyes. So we can track them once you inject them intravenously. And here we're injecting them right behind the right orbit, where there's a venous pool there, and they eventually get into the circulation. And then we're imaging the whole mouse here for the lung. And we could see that the exosomes from the breast cancer cells that are lung tropic are actually found in the lung. To see this picture, it's just like a virus. You need hundreds of extracellular vesicles to get into a cell. And you could see the exosomes from the bone tropic and the brain tropic are not well seen here, really highlighting, oh, maybe the extracellular vesicles are responsible, explaining why that breast cancer likes to spread to lung. The extracellular vesicles get there first, promote an environment that the tumor cell then follows. And if we image the brain, we see the exosomes from that subclone tumor cell line present in brain cells. So it's very exciting. We can inject anything. So if you inject pancreatic cancer exosomes intravenously, they predominantly end up in the liver. And if you inject lung cancer-derived exosomes intravenously, you could find them in all rare sites of metastases, such as the adrenal glands. And there's people that work on eye melanoma, which is distinct from ocular melanoma, which is distinct from skin melanoma. And ocular melanoma likes to spread instead of to the brain, where it's close, actually likes to spread to the liver, and those extracellular vesicles are going to the liver. And this is just not work by my lab, but replicated by many labs around the world. And what we found is that specific packaging of the integrins were found and dictated which organ these extracellular vesicles would be seen. And there are also specific cell uptake. For the most part, macrophages are taking up these extracellular vesicles, but in the lung, the fibroblasts especially are a predominant cell, as well as epithelial cells. that are also taking up these extracellular vesicles. So to get them to go to the liver, on the surface of the extracellular vesicle, we have an integrin alpha V beta 5, and they fuse with Kupffer cells there. And in the middle panels, the lung, and we see alpha 6 beta 4 and alpha 6 beta 1 on the surface of the extracellular vesicle. And then we see alpha V beta 3, as well as a new protein that's a hyaluronic acid binding protein called CMIP that promotes these extracellular vesicles to be uptaken by cells in the brain. But the story of the integrins is not just about organotropism. We have a paper that's being reviewed right now by a talented postdoc named Serena, who's now an instructor. And what we find is that this integrin beta 2 is important in clotting. And so if she takes the primary tumor exosomes and inject them into healthy, normal, naive mice, nothing happens. They'll just go to the organotropic sites that I mentioned. If she takes normal exosomes or even tumor cell line exosomes, nothing happens. But really remarkably, if she takes the metastatic lung, where you already have melanoma spread to, and dissect the normal part, not the tumor cells in that metastatic lung, and inject those exosomes, you get immediate clot formation in the healthy normal mice, and they die within minutes to hours after getting an exosome injection. And here you could see platelets and fibrin, and here's a beautiful picture. Look, there's just many, many platelet clusters, and you can actually see the exosomes from that metastatic tissue being present. So this is interesting because everyone says clotting is, clotting factors from the liver, and so many people that study clotting say it's all about tissue factor starting the whole process. And this paper is really going to come off and say, no, it turns out to be interstitial macrophages, which aren't well studied, are actually secreting exosomes that through this beta 2 integrin that bind platelets that starts all clotting. And this is the exact same clotting that you see in COVID-19 patients. So we have a paper ongoing studying that. So it's a common mechanism for all thrombosis in cancer patients. So if you take metastatic, liver exosomes, you get no clotting. Metastatic bone exosomes, no, it has to be involving the lung. And so here's really an example about the systemic effects of cancer. So if you have pancreatic cancer, you're sending exosomes to the liver and making that liver very pro-inflammatory and getting ready for liver mets, which is not good. But don't think the lung and other tissues are healthy when you have pancreatic cancer. So we actually find a chemokine, CXCL13, that interacts with these interstitial macrophages, and they produce these integrins, beta 2, that are clustered on the surface of the extracellular vesicles, and they can form clots. And you see the clots all here. So it's very exciting because that means not only if I just treat and prevent the liver mets, I can't just stop there because that I'm actually going to allow more clotting to occur in the lung, and the patient's going to die right away. So I have to think really strategically and block that clotting process that's taking place in the lung as well. And we're very excited with this just simple beta 2 treatment because we can allow mice to have full-blown metastases and start treatment. Here's 6 courses of targeting beta 2 integrin, and you could see not only are we preventing the clots, but we're actually reducing the metastatic burden here. And this is very exciting. This is what you start treatment. Look at this. There's melanoma everywhere in that lung. And now you have some areas where you have normal lung function. So we're very excited. We're mechanistically trying to figure out, is it just about clotting that leads to metastases, or does this target beta-2 integrin also somehow target the metastatic tumor indirectly? So we're trying to figure out the mechanisms involved. But this was kind of an unexpected result. And so this is extremely exciting, because that means we can extend survival in mice, hopefully with patients, with a simple integrin treatment that's not well studied as a target. And this is something that could be for the metastatic patient who's also prone to clotting. We could treat both aspects of the disease. And so we're very excited. We're actually advancing technology. So we have a microscope that uses different antibodies, and we can image single extracellular vesicles. If you're going to do drug company development, out of 100 vesicles and you want to target them, how many of them have this clump protein, beta-2, that I mentioned? And so here's a normal melanoma cell line, and you could see some of the beta-2 protein on that single extracellular vesicle that's scattered. Now with the clotting, as when you have cancer, these interstitial macrophages are releasing vesicles, and it's all clumped to one side. And this clump format is almost similar to what's seen in the cell. Then they start binding platelets, and then they start forming clotting. So we actually can target the activation site. So it happens to be alpha X with beta-2. You can target just generally beta-2, but then you worry about normal cells that may have some beta-2 expression in their extracellular vesicles. So we're doing more antibody targeting on these active sites, and that way we would eliminate side effects. We wouldn't target your normal bone marrow cells, and we would only target these bad interstitial macrophages in their exosomes. So the list of integrins is growing, and it's getting very exciting. And we keep finding out, we found another integrin for breast cancer patients that predict bone mets. And so we have over 200 patients that were followed 20 years. We get a plasma sample, we isolate the extracellular vesicles, and we found alpha-5 integrin on the extracellular vesicles right from the beginning at diagnosis. You know how everyone that studies bone mets says something happens 4 years later and allows the bone mets to grow? No, we actually easily identify who's going to have bone mets even at diagnosis, blinded. We were correct on every single one. These samples were given to us by Fred Hutch, and so we kind of blew them away. They couldn't believe that we could predict. So there was over 100 exosome proteins that are associated patients that 4 or 5 years later develop bone mets. So if you can identify them early, you can do something about it. And so here I mentioned there's at distant organ sites. This is what the picture looks. That's how we got into the field. They were present at these distant pre-metastatic niches, and we saw a picture of tumor and tumor-associated cells releasing exosomes at these distant sites. And you can see they're very heterogeneous. That's kind of the theme. Not only are the cells heterogeneous in the tumor microenvironment, but the secreted extracellular vesicles are too. So we developed a new system called AF4 fractionation. It's like putting particles in a swimming pool. The heavy particles go to the bottom. The little exomeres are on the surface. And then you just simply apply two forces, a parallel force, a perpendicular force, and the exomeres will travel across the pool faster than the heavier particles, and you can collect them. So we have three particles that are really seen at distant organ sites. Exosome large, 90 to 120 nanometers, exosome small, and these new exomeres less than 50. And then you could ask what's inside. If we look at proteins, the exomeres really package all these proteins here, which many of them are metabolic enzymes or metabolic related proteins, very different from the exosomes. And if you do pathway analysis, you could see glycolysis and mTOR signaling. And we get hints that the exosome large cargo is involved in immune cell regulation. Here we see IL-2 and STAT5 signaling. And luckily, we can label all three and inject them into naive animals and just ask, where do they go? Simple. All our work is very simple. Where do they go? Let's look. And then we learn what their role potentially may be. And here you could see the large exosomes. We're injecting them intravenously behind the eye. They end up in lymph nodes as their favorite target. So somehow the venous system and the lymphatic system, they're kind of communicating with each other. And so do the large exosomes promote lymph node metastases? And are they the ones that are involved in immune suppression? So we're learning all about that. The small exosomes are going to distant organs. So these are melanoma. They're going to the lung. So do the small exosomes promote distant metastases? And then you look at the exomeres. Well, where are they going? They're not going to the lung or lymph nodes, but they're predominantly going to the liver. What are they doing there? That's the question we ask. So if we can study models where they're not metastasizing to the liver, say they're spreading to the lung, the exomeres will go to the liver on their own, and you can ask, what are they doing there? And so this project, we use extrahepatic metastases. So that would be like melanoma that likes to spread to the lung, but their exomeres are going to the liver. And so here we're just injecting these tumors, melanoma, and I'm showing you another one, osteosarcoma, that only metastasizes to the lung. But we're making the presumption that these exomeres are going to the liver. So this is just injecting tumors. Everyone thinks the liver is normal when you have melanoma. Let's just focus on the lung, where you're going to have lung mets. The liver is normal, so let's not study it. It's actually very abnormal. And so if you do RNA-seq and pathway analysis, inflammation, TNF-alpha are upregulated. Downregulated is fatty acid metabolism and OXPHOS. When you look at metabolomics, there's no arginine, and the urea cycle's affected. Everything is like really affected metabolically in the liver. So how can T cells function? And then what you see is cholesterol, ceramide, triglycerides go skyrocketing high. So often in a cancer patient, the doctor's like, oh, your cholesterol's 500. Did you ever have high cholesterol? No, like I had it tested 2 years ago and it was normal. Oh, we won't worry about that cholesterol right now. Let's worry about your cancer. And when you have cancer, your cholesterol, triglyceride, and ceramide go up, explaining why there's such a high rate of cardiovascular disease in cancer patients. So someone may say, oh, they didn't die of the cancer, they died of a heart attack. No, they actually really died of the cancer that led to that. I have 5 minutes?
Yeah, we saved 10 minutes for the discussion. So you have
Perfect.
conclude.
So here you could see the liver, and it's very fat with the stain from melanoma patients, osteosarcoma. It's like black and white. So they develop fatty liver disease. It's not everyone thought in medical school that fatty liver disease precedes cancer. No, cancer can make the fatty liver. And here you can see a patient, the patients that develop lung mets that have pancreatic cancer that we follow 8 years from their diagnosis, they're the ones that had fatty liver. So if you have liver metastases, you have inflammation, not fatty liver. If you have fatty liver, that's a sign that they're probably going to get lung mets instead. And here's just showing when we inject exomeres by themselves every other day for 3 weeks. No matter what model, we use more than 12 different tumor models, you get fatty liver being generated. We can target that by blocking with TNF-alpha, which is upregulated in these Kupffer cells with the exomere education. So if you give the antibody and prevent that upregulation, you can really tone down the fatty liver and restore normal metabolic function. And this is a whole new area that we're very excited about. Palmitic acid and other unsaturated fatty acids are highly packaged in the extracellular vesicles. Normal extracellular vesicles from normal cells will not have these fatty acids. So this is like a big thing for Sarah Maria Fent from Belgium. She thinks palmitic acid in the pre-metastatic lung is really promoting metastases, and we actually show it may be partially explained by palmitic acid in the extracellular vesicles of cancer extracellular vesicles. And so here's the models of treatment that I'm going to suggest. So if you have liver mets right here, you're going to see those neutrophil extracellular traps that I showed you. So we got to target those nets. And can we prevent liver mets? But we can't ignore that pancreatic cancer is sending out growth factors that your mom highlighted. This one's CXCL13, and that influences the lung and causes a prothrombotic lung niche. So you got to think of both. And if you have lung mets, say like melanoma, here we see these neutrophil extracellular traps in the lung. We got to target those. But here I showed you the exomeres are causing fatty liver and metabolic dysregulation with some of the factors I highlighted, which means you can't metabolize chemo. How can you? If you can't metabolize chemotherapy, you're not going to be cured. So we're offering this multi-organ systemic therapy, lung and liver metastases. You have to use all these combinations. PAD4 inhibitors blocks the nets. And then depending on if it's liver or lung mets, there's all these other inhibitors. And so I just wanted to end quickly. This will take me 1 minute. You could use all these exosomes in patients and predict whether you have cancer or not. So we did a big study with 500 patients. We identified new exosome markers like stomatin. And we simply get the tissue from the operating room, adjacent and distant tissue and blood. We chop up the tissue, and then you can analyze these patient exosomes. I'm going to skip that. Some of the interesting markers are ECM markers, and Ruthie will tell you that's no surprise because pancreatic cancer is 90% CAFs. So we see very interesting extracellular markers like Bursican. And if we look at just exclusive proteins on the cancer side versus adjacent tissue exosomes, again, we have pro-inflammatory markers, but we have a lot of these ECM markers as well. And finally, I just want to say we're all interested in a blood sample. When you get a blood sample, it's not just tumor exosomes. It's all other exosomes that are abnormal, such as immune cell exosomes. And so this is the end, showing that when you get a blood sample, yes, we're really doing a good job matching everything, tumor, adjacent tissue, distant tissue, lymph nodes. so on, and blood. And here you can see that all these abnormal exosomes are coming from different sources, which really improves the strength of the exosome test. You have cancer and prognosis. And so in conclusion, the integrins are important in prognosis. I hope to highlight that exomeres can shut down the liver. And so the important part is we have to start thinking of multi-organ therapeutics to really help the cancer patient. And we think these extracellular vesicles really can be an advantage, say, from circulating DNA for diagnostic and prognostic. And these are all the talented people in the lab contributing to the lecture today. So thank you all, and sorry I went over a little bit.
Thank you, David. Thank you, David. Just a little bit, so I think we have time for questions. Yes.
David.
Yes, Ruthie.
Thank you for a beautiful talk, as always. So the integrin beta 2 story, can you talk a little bit about it as a treatment? So
Yes.
resistance. Thank you. So do you start seeing resistance over time? And you mentioned trying to target it more specifically to avoid the normal
Exactly.
side. So can you talk about that?
Yes,
a
so
little bit?
in the lab, we're developing the antibodies specifically at the active site where alpha X and beta 2 bind together. So we're not really targeting beta 2 that's resting and dispersed. And so we only have done like minimum treatments, and we're already extending life in the mice by 3 weeks. So after 4 treatments only, the mice, that's a big deal, are living 3 weeks longer. So now, right now, although we sent the paper in, we're doing 3-week treatments with beta 2 to see if we can get like 2 months survival or so. And there's no side effects in the mice. So we carefully look at their bone marrow, which has beta 2 integrin expression, but as I said, we're really targeting this active binding site, avoiding the side effects. So we're really kind of excited about the whole thing. With increased survivor, decreased metastases, decreased clotting, can we offer this as a new treatment for the metastatic patient? Yes. Hi, how are you? Anik.
Fine, thank you. Thank you very much for this great talk. Maybe I missed something, but can you modify the target organ by introducing ectopic vesicles? Like, for example, you have a tumor that
Very
goes in
good
the
point.
lung, and you just modify.
Yes. So we're actually, it's like the war of the worlds here between the exosome world. So the tumor exosomes are like, the Star War bad exosomes. Can we use good exosomes and get them to go to these sites? You asked the most brilliant question. And so we have people doing exercise studies proving that the good exosomes from your thymus gland, everyone thinks it's burnt out. There's plenty of good exosomes from your immune system that are going to the liver and lung, blocking the tumor exosomes from being taken up, explaining why breast cancer patients on a chronic exercise program do well. But lazy people like myself, who never exercise but just keep eating this wonderful French food, we actually can take T cells, even from the blood bank, isolate T cells. So we're studying the good immune cells and their exosomes, and we're showing that we can inject them, and the tumor cells are taking them up, and antigens are being presented, and all the tumors, even cold ones like pancreatic cancer, triple-negative breast cancer, brain tumors, we get regression, complete regression of tumors. So that's I think one of our biggest discoveries. So we can use immune cell healthy exosomes and combat cancer, because cancer's hijacked your immune system. Those bad exosomes are getting in there. They're no longer doing what they're supposed to be doing. From another source, if we get the good immune exosomes, we can re-educate the cancer and make it regress. So I think it's one of our big discoveries of the upcoming year. Thank you.
That's fantastic.
Yes,
hello.
hi, Grasa. As I mentioned to all of you, I don't know if you were here, she's going to get embarrassed, but she's like our world leader with clothial theory, and here they are, right here. You don't even need me to come and present today. And we're really honored. You've made major contributions to this field. As I was saying, there was a handful of people, and because of you, there's like 5,000 people coming to our exosome meetings now. So we thank you.
But we would really like to thank you. I mean, I think it's fabulous. I mean, all this work is amazing. And we have many questions. I hope we have time to talk today afterwards. Basically, I think the exomer has been really, really a mystery for us because there's no membrane. So my question related to these studies is more like, it's true, they end up in the liver. Sometimes, when we have used model organisms, we know that, as Guillaume Vanille has shown, for example, some of these small exosomes can be taken by patrolling macrophages and be degraded in the liver. So how is the exomer not degraded in the liver, by the way?
Yes, so that's a really good question because there's some exosomes that are promoting the immune system and some that are actually exosomes that make the immune system pro-tumoral. Yeah, so that's what we're trying to figure out because they're actually exomers from the good cells that aren't well characterized yet. But for sure, the tumor exomers, no matter what tumor we use, are not like favoring a healthy immune system. As I mentioned, we used 12 different models in the paper. It wasn't just osteosarcoma and melanoma. We used transgenic system. They're all doing the same thing, upregulating TNF-alpha, which is the main player for fatty liver disease. So once it's educated in the Kupffer cell, it starts educating the hepatocytes. All those chemokines, local ones, are educating the liver to be fatty liver. So far, it doesn't look like the exomers are supporting a healthy immune system. It's really full of has a metabolic education, the bad metabolism taking place in cancer, explaining why you lose fat, lose muscle, and gain fatty liver. Now that organ's huge to supply energy needs by the cancer cell. And so, we don't see tumor exomers doing anything good, but in our hands.
They are responsible for cachexia,
Indirectly and directly. So they like to go to brown fat. I didn't get into that. So it's kind of an exciting area.
Danielle is telling me too.
You talk to me. I think we can take the last question now.
Thank you, Daniel.
Thank you very much. This tissue-specific tropism of your EVs, depending on different integrins, is really fascinating. So do you think there might be a role for a tissue-specific vasculature in the uptake? And why in the bone marrow you don't have specific integrins driving the uptake of EVs?
Yes, so I kind of mentioned that alpha-5 integrin is important in the bone marrow. But as you said, EVs, besides going to these organotropic sites with integrins, they always end up in the bone marrow even without the integrins. And so that's an important role, what cells are being taken up. And I think, like an area that we're interested in, it may not be integrins, but we're finding advanced aging. If your bone marrow ages, guess what? The whole host starts to age. You can have accelerated aging, and we think it's due to the extracellular vesicles in the bone marrow. So we're still trying to figure out why they're so readily taken up by immune cells and bone marrow cells, and it may not necessarily be integrin dependent. And then your other question was what? I'm sorry.
It was about tissue-specific vasculature and its
Yes,
role in the specific
so
uptake.
we do see the endothelial cells having a major role in uptake, but surprisingly, we're actually studying like hours after we inject. And so we have a paper on vascular leakiness in the lung, and it's the interstitial macrophage that still takes up the extracellular vesicles, and then they release interleukin-6 and other factors that cause the endothelial cells to have vascular leakiness. But in general, after the macrophage, I would say the endothelial cell is also taking them up in organ-specific manner as well. And whether that's integrin-dependent or not, we haven't really figured that part out yet.
For sake of time, I think we should move on.
Thank you so much.
All right.